Hello, everybody, and welcome. My name is Dominique. I am the member of a public education committee for ADAA, that's the Anxiety and Depression Association of America. Welcome to our webinar, When to Worry About Your Child's Worry. And our presenter is Dr. Rachel Bussman. Before we start, I'd like to say a little bit about ADAA, the Anxiety and Depression Association of America. ADAA is the leading nonprofit organization in the field of anxiety and depression. Our mission is to improve, diagnose, and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, practice, and research. We work to end stigma and to get the word out about these conditions, that they are real, serious, and treatable. I want to invite you to visit ADAA's website and its fabulous resources, ADAA.org. You'll find a great list of treatment providers. Just click Find a Therapist from the homepage, as well as a free peer-to-peer online support group. And you can support ADAA by making a charitable donation on the website. Okay, so let's get started. Today's presenter is Dr. Rachel Bussman. Dr. Bussman is the Senior Director of the Anxiety Disorder Center and Director of Selective Mutism Services at the Child Mind Institute. She leads a team of clinicians providing evaluation and innovative treatment to children with Selective Mutism. Dr. Bussman is President of the Selective Mutism Association, the nation's largest network of professionals, families, and individuals with Selective Mutism. Dr. Bussman has an extensive experience providing cognitive behavioral therapy to children, teenagers, and young adults struggling with anxiety disorders and school difficulties. She also has specific interests and expertise in the evaluation and treatment of obsessive-compulsive disorder, separation anxiety, social anxiety disorder, and specific phobias. Dr. Bussman is dedicated to establishing trust and instilling a sense of hope in her patients as she helps them on their path to recovery. And with that, I'll turn it over to Dr. Bussman, who will be presenting on when to worry about your child's worry.
Okay, hopefully you can see my slides. And my name is Dr. Bussman. I'm a clinical psychologist and the Senior Director of the Anxiety Disorder Center at the Child Mind Institute. And I'm going to be talking today about when to worry and how adults can help. So I'll just speak very briefly about the Child Mind Institute, which is an independent national nonprofit that's dedicated to transforming the lives of children and families. We are based in New York City, and I just want to highlight a few important things before we get down to the details of the talk. So why is it important to talk about anxiety disorders? There's a real need to do this. Mental health and learning disorders are real, common, and treatable, and you'll see on your slides some important and valuable statistics about diagnosable mental health disorders, age of onset, and we'll talk in a little bit about some of the barriers to treatment. There'll be probably more slides than we'll be able to cover during the webinar, but I'll have my contact information at the end, and hopefully the slides will be very helpful to you. So we do a variety of different types of interventions at the Child Mind Institute, including research, direct clinical care, and public education, which is why it's wonderful to partner with ADAA as we share the mission to equip parents and adults and educators with accurate information about mental health disorders. So we have a lot to cover in about an hour. And so this is just an outline for the presentation, which will start with a discussion about normal fear and move into more specific areas of anxiety disorders. I'll talk a little bit about how they are different, and you'll notice that there's some significant overlap in some symptoms of anxiety, and then what it looks like in kids, when to get more help, and what an adult or a parent can do. So it's important before we talk about anxiety to actually talk about fear and the fear response. Fear is a really normal and adaptive set of processes that happen in the body and in the brain that alert us to when we're in danger. And so this is very important so that our species, so humans and animals, can survive, because when we perceive a stressful threat, we send signals in our brain and through our body to respond quickly. So I use the example often because I live in the suburbs that deer often jump in front of a car, and this has happened to me many times, and I have to slam on the brakes very quickly. And I often have a lot of physiological responses as a result. So most recently, when I slammed on the brakes, I also felt my heart rate quicken, and I felt like I was having a little trouble breathing, and my stomach felt a little bit nauseous and queasy. And those are all ways to know that your fight or flight system is being activated. So when there's a danger, we often get ready to fight or get ready to flee, and sometimes we freeze. But the idea is that this happens very quickly and really outside of our awareness. So having a fearful response to a stressful event or danger is very important. This becomes a problem when there is a signal sent that there is danger and there really isn't, or when there's an exaggerated response to maybe a minor threat. So we'll talk about that in a bit, because this is really relates to anxiety disorders. So here are just a couple of cartoons that sort of highlight this idea of fight or flight. And I really like the one with the shark, in this idea of like fear is a response to an immediate danger, whereas anxiety is more related to the rumination and the stressful responding that you have even outside of the presence of that stressful trigger. So you see that the little fish is worried about this big shark even when the shark's not there. So this might be a little hard to see, but the graphic is meant to describe that a lot of things are happening in the body and in the brain when our fight and flight system is activated. And so there's lots of neurochemicals that are coursing through our brain, and blood is being sent to big muscles in the case that you need to run fast from, let's say, a grizzly bear or a respond quickly in the face of a threat. It also explains why our stomachs sometimes get upset, or we feel like we have to go to the bathroom when we're stressed, because when you're digesting a hamburger and you're also running from some kind of danger, you don't really need to digest at that time. So energy is diverted away from digestion and goes to our larger muscles. And then when everything kind of resets and goes back to homeostasis, then you might feel stomach upset. So fears are often normal, and it's not uncommon to hear sort of themes that are pervasive through different stages and ages of kids. So monsters under the bed or something scary in a closet is often common to hear with younger kids or 5 and 6 year olds. Themes of kind of separation and fears of separation can often happen at this age, at a younger kind of preschool and elementary school age. And then we sort of see other things that can emerge as kids get older, trying new things, specific things, meeting new people, and more social worries about where one stands in their peer group or what other people think of them. So an important question that we often get asked is, when does anxiety or worry become a problem? And so we think of a couple of different things. We think of how frequently, or the frequency of a child or an adult, but we're talking about kids today, how frequently a child is experiencing a certain set of symptoms, which we'll talk about in a minute. So frequency, duration, how long have the symptoms been present? And usually there's some kind of guideline for how long symptoms are present for. And a really important one is impairment. So everybody probably has a little bit of worry about different things or feels a little blue sometimes, but really one of the important factors when thinking about a diagnosis of an anxiety disorder is how much do the symptoms and how long they've been around interfere with one's ability to do their job. And to me, a kid has a job. A kid's job is to go to school and to be part of a family and to have friends and be socially interactive. And if they're not able to do that because of anxiety, we would say that that's a significant problem. So here are a couple of examples. So let's say we have an 8-year-old with a little bit of nervousness about going to school. It's September. It's a new school and a bigger one than last year. And we see some tears at the bus stop and then generally a good day, and this lasts for a few weeks. And so that could definitely be considered something normative. Not every 8-year-old who transitions in a school is nervous, but some are, and that could definitely be seen as quote normal. So these are examples of different types of things that could be considered normal, but would certainly beg for the clinician to ask more questions, right? Especially, let's say the 10-year-old doesn't like to hear about getting sick, hates hearing about vomit. Well, lots of people don't like to hear about vomit. Lots of people don't like to think about getting sick. And sometimes there are kids or adults who get so upset about the idea of getting sick that it interferes in their ability to, let's say, sit in the cafeteria or eat a meal. And that's when we get more concerned and we think about anxiety disorders. So we're going to talk a little bit about what these anxiety disorders are and why we need to intervene. Again, there are a couple really good slides here about one, the amount of kids who have a psychiatric or learning disorder and some of the risks associated with it. And then the next slide talks a little bit about the barriers to treatment. And again, this is why public education and outreach is so important. And this is why organizations like ADAA have Find a Therapist button on their website so that we can help break barriers, decrease stigma, and help people access evidence-based treatment. So we're talking about anxiety. So we're really talking about a pretty significant number of kids having an anxiety disorder. And you can see at the bottom of the slide that there are a lot of negative consequences for untreated anxiety or any psychiatric or learning disorder. It puts kids at risk for problems in school, problems with peers, problems with getting a job. I work with a lot of younger kids, and oftentimes I might not be thinking about risks of alcohol and substance use, but I'm definitely concerned about being able to go on play dates or sleep away from home. And so there are short-term negative outcomes as well. And then we see barriers to care. And this is a lot of information, but I'll just highlight a few things. One of them being that quality care is hard to get sometimes. There's a high need for care and not always enough people to provide that care. There's also stigma that surrounds psychiatric disorders, and that a lot of times families, by the time they seek treatment, it's been a while, maybe a year or even longer. And we want to really reduce the amount of time between onset of symptoms and access to care. And so we want to make sure that we're paying a lot of attention to kids and kids in anxiety or kids in other kinds of psychiatric disorders. So this one's a really important slide because it's very important to know that anxiety can look like a lot of different things. And so you'll see on the bottom of the slide, there's this set of double-sided arrows. And so we could all kind of conjure up in our minds what an anxious child looks like. And in my mind, I'm picturing a child who's maybe crying and has their hands in their mouths and might be trembling. And that we probably would agree that that's what anxious looks like. But other kids present their anxiety in other ways. For example, it might involve really withdrawing and looking very shut down, looking very, quote, shy, or not talking or not engaging in an activity. On the other end of the spectrum, kids who are anxious can actually look really inattentive and really distracted, or they could actually look really disruptive, meaning what might be labeled as misbehavior. And all those things could be due to anxiety. So if we think about a child who is maybe running from a situation or enters kind of an anxiety-provoking situation like a classroom or a party or a new situation, and rather than withdrawing and clinging or hiding, they kind of stomp their feet or push things out of the way or even push somebody or pinch somebody, we could label that as misbehavior, but it could actually be due to anxiety. And that's actually really important to know. So what does anxiety look like in school? So sometimes it looks different in school, but these are some things that teachers sometimes report, that a child is taking a lot of trips to the bathroom, or they're having trouble in certain subjects or problems with their grades, not turning in homework. So kids might not turn in their homework because they didn't understand it. They could not turn in their homework because they lost it. But a lot of kids that I work with don't turn in their homework because they are really nervous that they might get in trouble because they left one blank, or they left an item blank, or they don't think it was neat enough, or they don't think that the paper was clean enough, or they're worried about what the teacher might think if they don't get everything right. we'll talk a little bit more, but I'll just highlight here this idea of reassurance seeking. So this means when kids ask a lot of questions, more than just asking for clarification. So if a child says, what time are you going to pick me up? And the parent says, I'll be there at 3, that sounds like you're giving information. But if the child asks every day, and maybe even multiple times a day, what time are you going to pick me up? Where are you going to be? Are you sure you're going to be there? Are you going to remember to get me? Those are what we would call reassurance seeking questions. So asking for excessive reassurance that something's going to happen. And so you see some other things that anxiety can look like, including really irritable mood, so crankiness or crying or tearfulness. So I'm going to go into the different anxiety disorders. And the DSM-5 is the latest version of a very large manual that lists all the different disorders that one could have. It's certainly not a perfect system. And there's sometimes there's some hesitancy around labeling or giving a name to something. I actually think it's really important to use diagnosis to drive treatment. And so I think it's really important to know which of the anxiety disorders is present. Sometimes they can co-occur, which means there can be more than one. And sometimes some of the symptoms overlap, meaning that one symptom in one category can be present in another. So these are the names of all the different anxiety disorders. And there are a lot, and it can be a little confusing to keep track of all of them. And at the same time, we're going to go through the disorders in a little bit more detail, so that what I'll do is I'll highlight some of the symptoms of these anxiety disorders and also highlight one myth. So maybe one thing that people often think about the disorder, but that isn't actually true. And so you'll see the way they're presented on this particular slide is a typical developmental progression, meaning that the disorders you see towards the top of the slide are ones that tend to start at a younger age. And I say tend because absolutely a 7-year-old can have generalized anxiety disorder, and a 12-year-old can have separation anxiety disorder. But as we talk about the different symptoms, it'll be a little bit more clear why they're presented in this way and what I mean by developmental. You'll also see that obsessive-compulsive disorder is not listed here, but I will mention it later. It's just that in the newest version of this DSM, it was moved to its own chapter and it sort of gets its own attention. Okay, so separation anxiety disorder is different than what's separation anxiety. So really most kids, most toddlers go through a normal phase of separation anxiety. So I often use the example of my son, Jackson, when he first went to nursery school. He went to a twos program, and he started a little bit before 2, and he was a kid who was pretty easygoing about separation. But when he first went to this program, it was new for him, and he was obviously young, and it was a new environment and new people. And so naturally, for a first couple of days, he was a little clingy when he was separating. And interestingly, he happened to wear his coat for the first week or so. And he also carried a bear with him, a stuffed animal, which eventually made its way to a cubby, and the coat came off. And we would consider that a pretty typical reaction to a new environment for a toddler. When I'm talking about separation anxiety disorder, this is actually slightly different than separation anxiety that a child experiences as a toddler. So this is a very common disorder, and what it has to do with is persistent and excessive fear when faced with the idea of separation or actual separation from caregivers. So what it involves is either or both a lot of upset at the time of separation, bedtime, going to school, being left with a babysitter, and also an attempt to prevent that from happening. So this sometimes results in children having a really difficult time separating for school. It sometimes, interestingly, doesn't always happen at the time a child goes to school. So I have an example where a 5-year-old is having a difficult time transitioning to kindergarten, and it's been kind of a rough transition, but he's actually doing fine going to school now, and it's not so difficult. But that during the day, he's really pretty tearful and asking where mom is and when the end of the day is going to come. And additionally, he has a lot of difficulty separating even when the parent is with him. So if they go somewhere like to a party, he has a really hard time even moving away physically from the caregiver and even trying different activities. Often kids who have separation anxiety disorder often feel like a stomach ache or a headache, or they just don't feel well. And it could be because anxiety can sometimes manifest itself in physical symptoms. And so what we see is kids saying often the night before they're going to have a separation, like before school, I really don't feel well. And it could actually be that they don't feel well, not just that a child is trying to get out of a situation. These are often kids that have a really hard time having a sleepover at someone else's house. And so what we also see is that we usually look for the symptoms to be present for at least 4 weeks, and that we would say that the distress is developmentally inappropriate for the child's age. So the myth here is that this only happens to little kids. Actually, that's not the case. There's often kids who are, 10 and 11 and can have separation anxiety disorder. And often these are kids who are also worrying that something might happen to them or their caregiver. So frequent complaints might be, what if I get sick or hurt and someone can't help me? Or what if my parent forgets to pick me up? Or what if they're not where they say they're going to be? Okay, selective mutism. Selective mutism is a disorder that affects about 1% of the population. And what it is a consistent inability to speak in specific situations where there's an expectation for talking. So often school. And the thing that's important here is that unlike how the child presents in these social situations like school or play dates or with extended family, the child is often described as a complete chatterbox at home. So meaning the child might be a very chatty Cathy at home, sings all the songs they did at school, but when they get to school, they might be completely unable to talk or talking to a very limited extent, maybe whispering or only with very select and specific people. The symptoms can't be a result primarily of a language problem or speech or language problem, although a lot of kids with SM or selective mutism do have a speech and language issue as well, but it can't be the reason for the non-speaking. And the child has to have comfort with the spoken language. So a child could be in a multilingual environment, but they have to know the language that's being spoken. And the myth here is that this doesn't happen with older kids. And an even bigger myth is that the child is refusing to talk, or it's what we call defiance. And that really is not the case. These are children that I treat often very much want to speak and feel like they can't, or there's just a lot of anxiety getting in the way of allowing them to participate in school and other meaningful social exchanges. So this is a slide to make sure everybody's awake, because we're going to go into talking about fears and phobias. So these are some pictures of some common fears. And because I'm someone who is a behavioral therapist and I do what's called exposures, I put the spider in there just to remind myself that I really don't like tarantulas, but I can look at pictures and tolerate it. So we're going to continue. So specific phobias are fears or anxieties about a specific thing. And common ones are flying, heights, animals like dogs or insects, getting a shot. And this is not just not liking something. So my grandmother doesn't love dogs, and if you brought a dog over to her house, she would probably shrink back a little bit and want you to make sure that you give her a minute to adjust to how the dog is. That's, maybe a little bit of hesitancy, but that's not a phobia. What a phobia is not only a lot of distress, a lot of anxiety, a lot of almost panic, when sometimes for some people, just thinking about the thing can generate, if we think back to that fight or flight response, maybe some sweating or some heart racing. I remember giving a talk like this in a room full of adults, and I was talking about snakes, and the person in the front row started to get very anxious, and she bravely said, let me talk to her about it for a few minutes, and said even just talking about it, even though she knew I was holding a pen and not a snake, was making her feel very distressed. And so the situation almost always provokes immediate fear or anxiety, and then is usually avoided. So if someone feels really scared to go on a plane, they might get on a plane because they really want to go to Disney World or somewhere else. But some people might just go places they can drive. Or if they don't like dogs, I've worked with kids who not only don't have a dog, but might not go to friends' houses that have dogs and avoid going to places like the park. And usually the fear or anxiety is out of proportion to the actual danger. So if someone said to me, I don't really want to swim in open waters where there's a lot of sharks, I would say that sounds pretty reasonable. So that would not be considered a phobia. That would actually be considered pretty smart to not want to swim in open waters with sharks. But most of us would agree that pets, dogs as pets, are usually pretty safe, and to have a fear that results in running or fleeing or not being able to be around a pet would be excessive. And so the myth here is that it's just overreacting. So often I'll hear adults or parents that I work with say, I just don't understand, like, why are they so scared? And if you imagine how you might feel if someone was threatening your life or was making you feel so on the spot that you felt like you were completely panicking, or said to you, I'm going to make you be in the situation that feels totally intolerable, you could imagine how someone could feel so panicked in a situation that is a phobia, right? So a child who is so fearful of bees or so fearful of an animal isn't just overreacting. They really feel that it's absolutely not tolerable to even think of it, to talk of it, or even be around it. Vomit is another not uncommon phobia or fear of choking. So I'm going to talk about social anxiety disorder, which is sort of like a cousin of selective mutism. So it can affect as many as 7% of children. And it's a fear or anxiety about social situations where the individual fears that they'll act in a way that will be somehow negatively judged. So what might be common is, if I do this, people are going to think I'm weird. People are going to think I'm dumb. People are going to think I'm ugly, or people are going to think I'm not good. So it has to do with how you think other people will judge you. And the social situations almost always provoke some fear or anxiety. And we might think of stage fright as a nice example of social anxiety, but it can actually involve things that maybe many of us don't think about too much, like eating in front of other people, or standing up and walking to the front of a room, or entering a room when there are a lot of people already in it. So those are probably things that many people do all the time, but that kids with social anxiety disorder might be really worried about, or making a mistake, asserting one's opinion, talking to authority figures are also things that can be very anxiety provoking for someone who has social anxiety. And so this is, again, really out of proportion to the actual threat. So we would probably all say that giving a presentation is probably anxiety provoking, but for someone who has social anxiety, their fears and their worries of how they will be able to cope or what their performance will be is really out of proportion to the actual threat posed by that particular social situation. And so the myth here is that it's just worry about giving a presentation. So I've definitely worked with kids who've had worries about getting up in front of other people, and that's not uncommon, but also saying the wrong thing just in class, not in front of a lot of people, maybe just a small group, or eating. For example, if I eat crunchy food, people are gonna say, why is she so loud? Or if I wear something with a collar, or if I wear shorts, people are going to think that my legs or my neck looks funny. So it can really be related to what someone wears, or how people speak, or what they're doing. Panic disorder is a disorder that involves recurrent and unexpected panic attacks. And I'm going to talk about what those symptoms are in a minute. And so not only does one have a panic attack, but following these episodes of extreme discomfort physiologically and often some thoughts that accompany it, there's a worry that it's going to happen again. So we don't have a room full of people, so we can't all raise our hand. But if we had to take a poll of the people watching this webinar, how many people have ever had any of these symptoms at the same time? So kind of unexpectedly have some heart racing or feeling short of breath or dizzy or chest pain. Probably most people would say at some point in their life that's happened, because it's actually pretty common for an adult at some point in their lifetime to have at least one panic attack. It could be in a specific situation, like about to give an enormous presentation, or sometimes people have these symptoms sort of out of the blue, which is what panic disorder is. The difference between panic attack and panic disorder is that those with panic disorder worry so much about having another panic attack and feeling either doing something totally out of control or dying, that the person starts to make changes in what they do. So for a teenager with panic disorder, it might be that they only can go places with a very trusted adult, or only go places if they have their water bottle. For some adults, this can often be, I can only go if I have some medication with me. And this can actually lead to a lot of avoidance of either things that are going to provoke these symptoms, because what happens is the person, the child or the teenager, starts to get really scared of these sensations. So it's kind of like the fear of fear. And so it's not uncommon for kids to not want to induce these symptoms. So I worked with a child once who had a lot of worries about having these physical sensations, which actually aren't dangerous in healthy people who don't have any kind of medical condition. And so he stopped going to the gym class and stopped wanting to walk quickly because he didn't want to have the feeling of a increased heart rate. So those are what panic attacks are. Now, all of the disorders that we've been talking about so far, and the one I'm going to talk about next, can all be accompanied by panic symptoms. So it's not uncommon to have some of these symptoms when experiencing anxiety about being in a group of peers, or when thinking about separating from an adult. The difference between panic disorder and a panic attack is, again, the disorder relates to these symptoms seemingly happening out of the blue and not in the context of another disorder. So just to make sure that's clear, if a child was having palpitations and they were shaking and they were crying and they felt like they were totally out of control when a parent was separating to leave them with a babysitter and the child had separation anxiety disorder, we would call that separation anxiety disorder, not panic disorder. And the myth here is that only adults have panic attacks, because while I don't treat a ton of kids with panic disorder, it definitely can happen and occurs in about 2 to 3% of teenagers. So generalized anxiety disorder, or GAD, is excessive anxiety and worry about a number of different things. And it's very difficult to control. So it means that the child is worried and thinks about, or ruminates might be a word that is used, about a lot of different things, not just dogs or not just separation. Often things like getting sick, or being perfect, or being on time, or the state of the world, or how things are going in the family, homework. It's oftentimes when I work with kids who have generalized anxiety, if someone mentions something like, oh, there's going to be a really big storm today in Florida, that could even get the child's anxiety going, even if the child doesn't live in that particular place. So it's kind of like worry about a lot of different things. And with it come some physical symptoms or some other kinds of symptoms, like being really easily tired, or being really irritable, or being tense, like having muscle tension, which makes sense, because if you're feeling really anxious or really worried about a lot of different things, your body probably wouldn't feel really good and you probably would have trouble sleeping. Okay, so OCD, or obsessive compulsive and related disorders. So I won't go into all the details about why these disorders are in a different category, but they are, and it has a bit to do with how some of the disorders and the neurobiological mechanisms are thought of. But at least here in the practice that I work in at the Child Mind Institute, we treat OCD and the related disorders within our Anxiety Disorder Center. So OCD is what I'll talk about, and with that comes some other disorders, which again have really big names, but I put in parentheses a better, like sort of an easier way to understand them. So hoarding disorder is when someone has difficulty getting rid of things of value, or even things that don't have a lot of value, but often have a lot of sentimental attachment to, or even just the thought of giving it away is too upsetting. Trichotillomania has to do with hair pulling, and excoriation is a skin picking disorder. But I'll talk a bit about OCD. It's a very debilitating disorder and can absolutely happen in children, sometimes young children. And the myth here is that it's just about germs. So we'll talk about the fact that OCD has to do with the presence of obsessions, which are thoughts or urges or images that are very intrusive, meaning they come into your mind without the child wanting them to be there. And they're really distressing and they're hard to get rid of. And compulsions are either repetitive behaviors or rituals that the child does to sort of neutralize that obsession. And the thing that's a little tricky here is the compulsion or the ritual can be obvious, meaning you can see it, like hand washing or walking a certain way, but it could be something called a mental ritual, like counting to a certain number or saying a certain word. And so the myth here is that it's just about germs or contamination, which is definitely a common symptom, but it could also be about worry about bad things happening to people, or worry about violent things happening. Sometimes kids have intrusive sexual thoughts or thoughts about God. It could also be intrusive thoughts about making a mistake, oftentimes needing to do things in a certain way, like a certain order, or do things evenly. Like if I brush my hand on the chair with my right hand, I have to even it up on the left hand. So, and that is what OCD is. And so, which leads me sort of to the next slide. So hopefully everyone's still with me on this presentation, because it's not meant to be daunting or overwhelming or overly negative, but to say that once you know what the anxiety disorders are, importantly, while we know anxiety disorders are the most common kinds of disorders, they're also very treatable, especially when caught early in the onset of this disorder and early in age. And so I'm going to shift a little bit to talk about treatment. And so I'll just leave this here for a moment, because as the presentation was introduced, the idea of public education, which again is very important, and reducing barriers to care, which I think starts with reducing stigma and thinking of mental health as health. So we know that there are barriers to treatment, and I'm not going to spend too much time on them. I'm assuming that if you're watching the webinar, you want to know more about anxiety disorders, and that's really good. So a thought, sometimes parents will ask me, when do I know that I should seek help? Like, how do I know if this is a disorder, or how do I know if it's not a disorder and it's just normal? And so to me, it's always important to it's always better to seek help and ask questions than wait and be not sure. But some important key factors would be whenever you see a significant change in mood or behavior that persists. So what does that really mean? So what it sometimes means is a parent might say, you know, my child's usually so easygoing and just wakes up happy all the time, and they've just been really, really irritable. And it's been going on for a while, like a week or two. That to me would be a change in mood. Or maybe the parent says, my child just seems to, like, their appetite doesn't seem right. They just don't seem hungry at all, or they're really having trouble sleeping. Those are examples of changes in mood or behavior. My son the other night had a really difficult time going to sleep, and it was for a day here or a day there. That's not considered a significant change in mood or behavior, because it's just everybody has an off day, or sometimes even an off 2 days. We always look at interference, and this is where I think talking to school is really important. Sometimes I work with families that are very hesitant to want to speak to school because either they're very private, or they feel like the child's doing pretty well at school and they don't want to rock the boat in any way. But if we think about them, most kids spend a lot of time at school getting some information from teachers regarding how a child's doing, how they're doing with their peers, how they're doing with their schoolwork, how they're doing talking, how they're doing in their specials and recess is really important, because it gives the parent a better sense of how the child's functioning in their job. Similarly, if a child usually does gymnastics or a musical instrument or Boy Scouts or religious education, and they just don't want to do those things, those would be indicators of when to get more help. Likewise, when a child is having persistent difficulties with peers or just not really wanting to have play dates, that would be a cause for concern, because we're social beings on a whole, and we're motivated to interact with other people. When I have red flags, I would say any aggressive or really out of control behavior, any threats to hurt oneself or any threats to kill oneself should really be taken seriously. And I think sometimes there's a question, do kids really get depressed, or do kids really commit suicide or hurt themselves? And the truth is they do, and they can. And so when kids do things that are really aggressive or dangerous to themselves or other people, you really want to seek help immediately. And another time to seek help is maybe you know your child's a little bit anxious and you've been trying to help them try new things, or you've been trying to help them have a sleepover at grandma's house, and that just hasn't worked so well. That's a really good indication that it might be time to engage a mental health professional. So I'm going to talk a little bit about some types of therapies, and then I'm going to talk most specifically about cognitive behavioral therapy, or CBT, because that has the most evidence behind it for treatment of anxiety disorders. And it's also something I can speak about because it's what I do. So this list is not exhaustive. There are probably many other types of therapies. But when we think about psychotherapy, we often think about these different categories. So one is supportive psychotherapy. And while I don't have a specific definition, the way I think of supportive psychotherapy is going to see a psychologist or a psychotherapist or a counselor or a social worker and kind of talking about your feelings and talking about what's on your mind. And the idea is to provide a listening ear and some support, but that it's not necessarily directive in nature or structured in any specific way. I'm going to skip CBT for a second. Family therapy is a very specific type of therapy. It's different than having a session for your child and the parent coming in for a few minutes. Family therapy is a type of therapy where the family is the patient. So rather than the child as the patient or the client, the whole family is seen as a system, that all the people and the relationships in it all have a role, and the whole family is treated. Play therapy is a type of therapy where the relationship between the child and the play therapist sort of is the therapy. And again, play therapy and something called psychodynamic play therapy are often a type of therapy where the child leads the interaction. And so the child plays, and often the therapist is interpreting the type of play that the child's doing, but it's not necessarily directed towards a specific thing like a phobia or specific anxiety symptoms. And group is a very broad category, because group, you can have groups that are behavioral or cognitive behavioral or dynamic, but group just means that there's more than one child in the intervention at one time. So I'm going to talk about cognitive behavioral therapy and say a bunch of different things about it. So CBT, or cognitive behavioral therapy, is really a type of therapy where there's an integration of behavioral, cognitive, and different theories of human behavior. So what we're really talking about is an intervention and a way of thinking about the child and the person in terms of how they think about things, how they feel about things, and how their behavior all sort of linked together. And so it's this idea. You might have often seen a triangle with thoughts, feelings, and behaviors attached to each triangle. And it's largely a treatment modality where there are a common set of principles, and that it is often present focused, meaning it's focused on in the moment now. And it strives to be a time-limited treatment that's pretty structured and focused on a particular target. Now, I think one of the myths that happens about CBT is that it's very much like a manual, or it's not playful. This isn't something you do with kids. And I definitely wanted to dispel that myth. So I am a CBT therapist, and I'm very playful. So there's a lot of play in work with kids. That's how kids interact, and that's how they express themselves. But unlike play therapy, there's a treatment focus and a target that and the interventions are geared towards that specific target. So we'll talk about that in a minute of what that looks like. So CBT often has some of these components of an assessment phase or an evaluation leading to a diagnosis. And that there's this really important part called psychoeducation, which basically is kind of a fancy way of saying that everybody, including the child, there's some explanation of what is happening and why it's happening. So if it's a phobia, it would be a discussion about why the child is having the fears that they're having, likely a combination of maybe some biologic predisposition, or maybe a lot of practice avoiding or staying away from the thing that was really scary, and the fact that a lot of people have anxieties or worries, and the education sets the stage for the techniques and strategies that are used that often involve things like how to have different kinds of coping skills, which might involve helping the child think differently about the situation. It might involve something called exposures, which are practice opportunities to do things, and we're going to talk about that in a minute. Like do things that to face fears, kind of do the opposite of what the anxiety tells you. Sometimes treatment involves relaxation training. I like to use relaxation training or just stress tolerance skills when anxiety is really at its highest and it's really hard to get through the moment. But the mechanism for change, for helping kids get over fears, is often doing things called exposures and using real life opportunities to practice of approaching situations rather than avoiding. CBT often involves homework, so out of session practice, because a child might see a treatment provider for 45 or 60 minutes a week, and sometimes it might be more, but oftentimes it's not. And there's lots of time in between that clinicians from a CBT perspective often see as really good opportunities to do things like track mood, track behavior, track using a particular type of skill, or do some kind of planned exposure. So let's talk about exposure. So an exposure is essentially a task or an opportunity to face rather than avoid a situation. So it's often seen as the very active ingredient of treatment. And so it means to face fears. And it also means to face fears while minimizing avoidance. So if I said that I was really afraid of tarantulas and I, for some reason, wanted to get over that fear, an example of an exposure might be to look at a lot of pictures, still pictures of tarantulas. But if I just looked at the pictures by flipping through the book and then throwing the book across the room, that might actually be a great start if I have not been able to hold a book ever. But if my plan is to go visit a friend or go to the desert where I might see spiders, that's probably not going to be a great exposure. So a good exposure is one where you actually stay in the situation for long enough to feel uncomfortable and actually get over the fear, seeing that probably nothing happens. Now, in the situation of a picture, definitely nothing's going to happen. Like, the picture is not going to come to life and hurt me. However, if I saw a real spider and I wanted to hold it, it might crawl on me. But the idea is that we're giving an opportunity to practice getting used to the anxiety rather than avoiding. So another example might be if a child has a fear of separating from a parent and going to a drop-off class or a play date. A first exposure might be just going with the parent to that activity and having the parent sit at the doorway of the activity for the entire activity while the child goes into the room, but the child is actually at the activity and stays there the whole time. And then maybe the next time they go, the parent moves 10 feet away or stays in the doorway but leaves 2 or 3 times during the course of the activity. But the idea is that it's planful and it's systematic, and it's a way of getting used to the anxiety rather than avoiding. And really, the goal is not to eliminate all anxiety, because that's really not possible, but to experience some amount of distress and actually be comfortable or somewhat comfortable being in a state of discomfort. So what can an adult do? An adult can do a lot of things, and I think an adult, a parent, can do a lot of things for kids who are anxious and kids who are at risk of being anxious, and also just for all kids. So it starts with just some education about anxiety and mental health in general. So if at the beginning of the talk we talked about fear and the fear response, if you didn't know that and now you do, then knowing that could be really helpful, because then you'd be able to sort of have that in your mind when you talk to your child about the fact that when we do scary things or we feel threatened, we might actually feel it in our body, and we might actually think things that are maybe catastrophic, like I can't handle this, or I have to get out of this situation. It also starts with having open communication. So an example of what that sounds like is if a child says, I was really scared to do this, and the parent says, oh, but meeting new people or having a substitute, that's not scary. That doesn't actually open the conversation up. It actually probably shuts it down. Versus if the child says, oh, I had a substitute teacher today and it was really scary, a way to have an open communication might be, oh, tell me more about that, or what was scary, or I'm really glad you told me that, let's talk about it. Another way that an adult can help is to be open to intervention and support, and also connecting with school to get more information, because school sometimes has a very similar take or might have a very different set of observations about the child. I also think this is really important, and I will admit that sometimes I do this myself, that I listen and jump right to solving problems before listening and letting the child come up with potential solutions. So it's really important and good for kids, actually, to not only talk about what's on their mind, but come up with potential solutions, even if those solutions are not feasible. For example, I really don't like having play dates with a lot of kids, so I think a really good solution would be to never do that and not to go to any birthday parties and just never have group play dates. So a parent might be inclined to say, well, that can't happen because you're getting invited to a lot of parties these days, or you're getting invited to a lot of sleepovers, and so that's just not realistic. But on the other hand, say, well, that's an interesting solution. So take all play dates that have more than 2 people off the table. All right, that's a solution. Now let's come up with some other solutions. And then we can go back and determine which solutions are feasible and not feasible. And probably the child's going to be able to come up with the idea that while that might be what their anxiety is telling them to do, it might not actually be possible to avoid all interactions with more than 2 people. And another really, really important thing is to model non-anxious coping. So what that actually means is talking about and showing, so more than just talking, showing your child that you can actually be brave during times when it's hard to be brave. So an example of this would be in my home, my son and my husband are extremely good skiers, and I am not a great skier. And in fact, when I first learned to ski, I was really, really scared. And so my son actually knows that because it's a nice metaphor for explaining to him that I was really scared to learn how to ski at age 30 and actually felt very panicked going up on the chairlift and getting to the top of the hill. And then it was only through practice and some lessons and some patience on my husband's part that I became able to do it a little bit better and actually enjoy it. So that's one example, but also just in day-to-day interactions, being able to model handling frustrations, handling worries, rather than escaping or avoiding. Another way is, again, we talked about recognizing signs of anxiety, but I'm going to come back to this idea of accommodation or reassurance. So accommodating is, in the way I think about it, is doing something that's an appropriate intervention until your child is able to do it on their own. So in our example of a child who has a very hard time and a real anxious response entering new group activities or a drop-off class, having the parent sit in the doorway of the ballet class or the karate class might be the thing that helps the child actually get in the room and would be appropriate in that particular situation, because it helps kind of provide the training wheels that's going to allow the child to have repeated opportunities to be successful, and then the parent would then kind of pull back their presence. Enabling would be once the child is able to do that activity, and a particular day they say, don't leave, but they've had lots of opportunities to practice and they've had lots of successes, the parent just says, okay, I'll just sit in the doorway like I did 4 months ago. So the difference is doing what a specific child needs in that particular moment, and that's what an accommodation is. And then reassurance seeking. So I think that we are often, as parents and educators and other adults, we often give our kids lots and lots and lots of information. And that's great, but when your child is an anxious child who seeks reassurance, meaning they ask the same questions a lot just to make sure, that actually maintains their anxiety rather than helps it. So for the child that says, when are you going to pick me up? Are you sure you're going to be there at 3 o'clock? And where are you going to be standing? And what if I don't see you? And the parent answers every single question. It actually inadvertently maintains the reassurance seeking questions, versus doing something like, okay, you can ask me 2 questions about pickup tomorrow. And after that, I'm going to say, I think we've answered that question already. I think you know the answer to it. So these are just a few other ways that a parent can help. I know that we're running a little bit low on time, so I'm just going to do one or two examples. So here's an example of a fear of vomiting. I treated a 7-year-old with a fear of vomiting. And again, this wasn't just that she didn't like the idea of throw up, but she was really worried that she was going to get sick. And she avoided sitting near the garbage can at school, or certain kids that had at any point in the past thrown up. She avoided certain foods at home that might make her more vulnerable to getting sick. Here's that reassurance where she would ask people, mostly parents and her teacher, is that kid going to be sick? And not just if the child was doing something like gagging or sounding ill, but even if they just breathed in a way that suggested that they might be ill. And so what was happening was all that reassurance and answering questions, and also accommodating the food preferences, meaning, okay, don't eat something that might make you nauseous, or yes, let's seat you away from the garbage can at school. And of course, Johnny's not going to be sick. He's fine. Actually was doing something called negatively reinforcing this child's anxiety. So treatment involved not only starting by providing some education around the fact that a lot of kids have fears, and a lot of kids actually have fears of throw up, but that we actually directly worked on this first with education about phobias, as I said, some education to the teacher, but then also exposures. So one exposure was sitting closer to a garbage can, eating some of the foods that had been previously avoided, moving a lunch tray closer to a child's lunch tray that had things that seemed suspicious. And it involved, and exposures need to be done pretty frequently. So it wasn't just doing these things one time. I'll do one more and then I'm going to have to end and say thank you to ADAA for having me. But I will talk about social anxiety. So this is a 12-year-old with fears of public speaking and also decision making. So making the right decision, making a decision that others might think isn't as preferable. And so one of the things that was happening was the child was videotaping their presentations, which was a temporary accommodation, which actually was a good accommodation. So meaning instead of giving a presentation at school, they were taping it on their, or they were recording it on their iPad and actually showing it to the class while they watched it as well. They would allow their friends to choose activities rather than say, no, I want to play this game or I want to go to this movie. And so, and this particular child had counseling on their IEP, meaning they had a special plan for school that allowed them to have counseling, but the counseling sessions pretty much involved just asking for reassurance. So the treatment involved connecting with the school and connecting with the counselor at school as an ally and a collaborator to reframe some of the interventions at school. The videotaping was sort of shaped to small groups and then to the whole class presentation. So we moved from videotaping to real presentations, but rather than a whole group, starting with a small group of preferred peers and friends, and then moving to more difficult peers. And then taking risks to choose activities, first with, quote, safe people. Like I would be okay making a choice in front of my best friend because she won't really care if I decide to play a game she doesn't want to play. And then the parents' role was really crucial here in helping them understand what social anxiety is and helping them to reinforce doing exposures and things that were actually showing some risk taking rather than avoidance. So I just want to move to some helpful resources, including childmind.org and adaa.org. So the Child Mind Institute and also the Anxiety and Depression Association of America, and some other really great websites and resources where there are often really great articles about anxiety disorders, really helpful resources to find a treatment provider in your area, or also find out about intensive treatments that might be a little bit further distance. And my contact information is at the bottom of the slide. Thank you so much to ADAA and for being present for this webinar.
Thank you so much, Dr. Bussman. And thank you everyone for participating in this webinar. And feel free to email your questions to webinars@adaa.org and be sure to write Dr. Bussman in the subject line. So bye for now, and we will see you next time.
Thank you.